Hi, I'm Dr. Peter Anglin from the South Lake Regional Cancer Center, and we're here to talk about the indolent lymphoma session presented by Dr. Michael Crump. Michael gave a great overview of what's happening with the American Society of Hematology meeting 2020, and we're going to frame that into Canadian context. We have Michael and John Curvella, and I'll let them introduce themselves, and then we'll get into discussion about the session. John?
Hi, John Curvella. I work at Princess Margaret.
Michael Crump. I'm a hematologist at Princess Margaret Hospital too.
And so we'll get started. Michael, you started with the watch and wait discussion, the watch and wait paradigm, which is something that is with indolent lymphoma we're all very familiar with, and presented some interesting data. And at the end of the day, you showed us that the time to next treatment can be delayed by giving rituximab up front to people with low bulk asymptomatic disease, but it doesn't seem to change overall survival. Is there a group of patients, Mike, that are asymptomatic with low bulk disease that should be treated with rituximab up front?
I mean, Peter, from the point of view of lymphoma biology, I don't think anybody's actually identified that group yet. I mean, that's an excellent question as to how we would, going forward, identify patients who are going to have an adverse outcome, how those who might transform early, those sorts of things. Right now, I'm not aware that there's any biomarker for that. Right now, the decisions are made, I think, really in the clinic room between the patient and the physician. There are those who are just not comfortable with being observed and would like the security of doing something. And we know from the trial, the Ardeshna trial that I showed, that the patients who are on therapy in that exact circumstance have less, basically less disease-related distress, less anxiety than the patients who are not on therapy. But it would be, I think, the next phase of investigations in this patient population is to explore early progression, much like we've done in CLL, to look for the patients who have a shorter natural history.
John, for that patient that has low bulk disease that is keen to be treated, and it is always shared decision making, how do you decide then between just giving rituximab versus, well, I'm going to give you BR, which we would consider our standard? Say it's a 50-year-old, and they're very keen for therapy and Michael alluded to some of those reasons. How do you manage that discussion?
Yeah, I have to admit, Peter, I mean, I've generally erred on the side of still saying, I think, unless you have, fairly standard indications to go on to treatment, that I would really try to spend the bulk of my effort in trying to educate and reassure the patient as to why early therapy in the absence of symptoms may not actually be the best in terms of longer term outcome from a strategy standpoint. I think if you're going to have that dialogue with the patient appropriately, I think the advantage, at least, of potentially initiating rituximab mono in that asymptomatic low tumor bulk patient may be potentially the argument around favorable toxicity, none of the risk of chemotherapy from febrile neutropenia, et cetera, but accepting that you're really not, I think, altering disease biology and natural history in any meaningful way. They're going to be needed, most likely, to be treated several years down the road, but it may be just the goal there to be the postponement of traditional chemotherapy, because chemoimmunotherapy would be our normal standard. So I can't say that I've given our mono in an asymptomatic patient, though it has come up in the clinic for discussion.
Mike, I want to get to, you referred to the GELF data, which is something we look at a variety of parameters that we would consider as potential indications for therapy. And there's a lot of stuff there people agree on, and then there's borderline things, 3 nodal areas with 3 centimeters of disease in a well patient. A lot of us can consider that borderline. Do you have any formal criterion that at Princess Margaret Hospital that you use for consistency of initiating therapy in patients with follicular lymphoma that you're following?
I think you probably identified the most important part of that, which was consistently used, because I think, as the Mayo data showed, there are patients who satisfy those criteria who are yet observed and still do fairly well, and they don't seem to have adverse outcomes compared to the patients who have less tumor defined by this criteria. And importantly, I think, the thing that everybody worries about, but may not be the biggest worry, is transformation. That wasn't more common even amongst the patients who met the ELF criteria. So I think, again, that's a conversation in the clinic. I think some of those factors, peripheral blood involvement, for example, I think to me is not a reason to treat somebody on its own. And I think, it's possible to follow those patients even if they have borderline ELF criteria, as you probably already do in your practice, and intervene when you have to. I have many patients who understand that they meet one definition of need for therapy, but they feel completely well and they have normal blood counts and aren't really aware of their disease, and they're quite happy to wait, and I'm quite happy to follow them. So I think we have to remember that those criteria really were constructed like the BNLI criteria to at least identify a group of patients for prospective trials, either observation if you don't have them or treatment if you do, really to make the clinical trials populations as uniform as possible. But whether or not you have to rigidly adhere to those criteria in clinical practice, I think we've seen is really not necessary.
I'm going to change gears here, guys. We do have some limited time. Michael touched on Waldenstrom's macroglobulinemia and some data looking at rituximab, dexamethasone, cyclophosphamide with or without bortezomib. Right now, in practice, we tend to give BR up front in the Canadian environment. John, I'm going to put this to you. Do you see this data of DRC with or without bortezomib? And the bortezomib didn't seem to add a lot, perhaps toxicity. But does this data influence your approach to Waldenstrom's macroglobulinemia patients who need therapy frontline?
I have to admit, not really. I mean, it was interesting to see, this group follow through on the data and actually do a frontline trial that integrated bortezomib in a systematic manner. I think that was useful. Having just had a discussion with a patient earlier today about starting therapy frontline, I made this point about there are a couple of different camps that are developing in the Waldenstrom's field. Certainly some are going to be influenced by myeloma-based practice where proteasome inhibition obviously is a mainstay of what's going on. I think a lot of us more with the lymphoma background are quite happy to generalize all of the data and experience using BR in this setting. And again, the data in Waldenstrom's are quite good with BR. And so, for me, I need to see a comparison that shows the superiority of that approach over traditional AR chemotherapy now.
The relapsed follicular lymphoma patient, that remains a challenge for all of us. And Michael, you showed us the ASH 2020 review. It's the flow diagram, and it's chemoimmunotherapy, and then what to do with a plethora of choices that you nicely outlined some of the options. Where does CAR T, and it's a loaded question, I'm going to ask you and then move to John, but CAR T and BiTE therapy in terms of impacting treatment in Canada, where's that going to fit in for follicular lymphoma going forward, and sort of timelines for that?
Yeah, it's not an easy question, Peter. I think we do practice this. According to that algorithm, people get a couple of shots of chemoimmunotherapy and then move on to clinical trials or other things. But I think we're also maybe recognizing that just a retreatment with chemoimmunotherapy or switching to obinutuzumab and chemotherapy regimen definitely have limitations to them. So I think I envision moving those therapies either bispecific antibody therapy or even CAR T cell therapy earlier. We've at our center have done that with autologous stem cell transplant in patients with early relapse. Centers do that with allogeneic stem cell transplant as well. So at least amongst the patients who have, short to disease-free survival on standard approaches, I think, in particular, moving away from chemoimmunotherapy as second-line treatment is quite justified. The data are, I think, encouraging to at least have develop more trials that will really test the worth of both bispecific antibodies and CAR T cell therapy. I think CAR T cell therapy has to be compared to something else before it becomes firmly entrenched as second-line treatment. Those studies were done in diffuse large cell lymphoma, and clearly patients and investigators were happy to accrue to them, and I would expect the same result if one of these companies were to launch a randomized trial of a CAR T construct in second-line therapy. You would have great accrual to that study in the high-risk patient population.
Yeah, John, let me ask you this. When we have patients relapsing with follicular lymphoma, and occasionally we can get them obinutuzumab chemoimmunotherapy, but that's a restricted population too by funding criterion. What should we be doing with the 68-year-old who's relapsing 4 years later? And I'm not talking about post-op progressions at 24 months, but 4.5, 5 years later, they're progressing. Your approach to, and who should we be sending and asking the CAR T question?
I mean, it's a great question, Peter, because, we don't have a ton of data to inform it. There have been, a couple of retrospective studies that have been published that, in the patients that don't have early failure, such as, the scenario you're describing, and like Mike mentioned, they can be retreated successfully with chemoimmunotherapy. And so someone with that longer remission duration, I think that's generally going to be a good solution, and the patient can continue on in the center they were previously managed for frontline therapy. I think the difficulty may be, what's the optimal second line approach? I mean, we just know that in people that haven't had bendamustine before, Steel 2 would argue, bendamustine should be in the mix in the second line setting. Beyond that, whether you go back to CVP, whether you bring in the anthracycline with CHOP, I mean, you can go back to the decision making that people have used for 10 or 15 years now or longer about the partner to give with rituximab. But some of the stuff that Mike also brought up in his presentation, a whole host of these new agents, multiple different PI3 kinase inhibitors available, other agents, and not just the more complex things like bispecifics and CAR Ts. I think bispecifics and CAR Ts are going to be, for the moment, at least placed, at least CAR T will be in the third line setting or beyond, potentially with high risk features that may move them earlier. But for the run of the mill patients still, they're going to have a decent remission duration, and there'll still be a lot of options. But I think the challenge in Canada is for some of these other drugs that are more readily available in other places, copanlisib that was approved, duvelisib that was approved, most recently the TG drug umbralisib has now been approved as well by the FDA. So, we don't have those drugs in Canada, and they probably haven't done the right trials in terms of a comparison, because, just to pick up on something Mike said earlier, we don't have a Scholar-1 follicular lymphoma data set that says here's a bad population that these drugs help in. And the populations have changed so much, you probably can't go back to a historic cohort in the same way that could be done with the CAR T population in DLBCL. Maybe you do need, unfortunately, you may need the randomized trial to really answer the question.
Is there any access, Mike, to you, lenalidomide rituximab R squared? We heard a lot about it 3-4 years ago, and we're getting updates on the data sets, but any experience with that in Canadian centers?
I think individuals, who are watching today will probably have, reached out to Celgene or through their reimbursement specialists to try to get access to it. Unfortunately, consistent access is challenging, and I think it's a good regimen for some patients. It's clearly active in frontline. It's adding lenalidomide to rituximab in a randomized trial where the rituximab arm actually behaved or performed pretty well, I thought. Clearly was beneficial. So I think that's probably at some level, maybe our healthcare system could work on, because I do think having an IMiD available in follicular lymphoma for some patients, because of the favorable toxicity profile, it's a relevant treatment, and I think we're going to need to work to try to get, maybe if not lenalidomide, one of the newer generation IMiDs into the hands of our patients, because I think it's a valuable recipe.
John, 1 in 5 patients that we treat generally with BR up front progress within 24 months. can we do any better for that group of patients? And in terms of access to trials, but in terms of that cellular therapy, BiTE, CAR-T at this point?
It's a great question, Peter. So, you know, I'll just make a general observation, which was that when you go back to the randomized trial looking at obinutuzumab frontline, there was a bit of a difference in terms of early failure, and that hasn't really been interpreted such to say that we should, go whole hog and adopt frontline obinutuzumab chemo. But that was something that there was a bit of a difference there. The trials that have looked so far at the bispecifics and at CAR-T were either in the high risk early failure POD type 24 population, and they've largely been developmental, right? So I think now we're at that point where, again, as came up in Mike's presentation, right? Like where are you going to position those, and is there a way to do it? And so, much like with what we saw with Zuma 12 and DLBCL, someone could find something to stratify patients up front and then try and transition. The plus side to the CAR-T data, both with the Novartis as well as the Kite product, the feasibility looks really good in indolent lymphoma. The question will be, can you find the right patient population, and will patients and clinicians accept the differential toxicity profile with CAR-T in the frontline setting? But again, it might be better built almost towards the bispecific platform. And I, asked the question, might say, since again, it's off the shelf, frontline, you're going to be exposing more patients, maybe an off the shelf antibody-based approach is maybe where the effort should go, and a more complicated procedure like CAR-T is likely to find its place second line and beyond just because of the complexity there. I don't know, what do you think, Mike?
I mean, I do think I agree that the portability of bispecific antibodies, being able to have therapy closer to home for many people who live in our province for sure, and in our country is going to matter. I think we're not going to. I think we're probably going to have to do some sort of triage there. But I think once you get past the first round of the first cycle or two and get up to the therapeutic dose for the currently tested bispecifics, the cytokine release syndrome pretty much disappears. So I think many centers that have who have experience with treating patients with advanced follicular lymphoma, not transplant centers, but regional cancer centers and busy hospitals, will be able to deliver that therapy. And I think that's really important. I think, and perhaps the value of CAR T-cell therapies are going to be in the really difficult to manage populations if we can, if we can come up with a biomarker to identify them.
Michael, thank you for your talk and the summary. Last words, highlights, comments from John, Michael, ASH 2020. Anything else jumping out at you? John?
I think it was kind of great just to see the sheer variety of what was out there. One of the things that Mike mentioned in the Mayo series really struck me, which was that, I had this number in my head that it was 2.5 years was the median time you could watch a follicular patient before they needed therapy. And in the Mayo series, it looked like it was even longer than that. And so again, maybe this is the shifting sands of earlier diagnosis, more frequent imaging in the US. I wonder what a Canadian cohort like that would look like. But, that was, to me, quite interesting, and maybe another powerful piece of information to give to patients to say, you may not need treatment for a long time. You may do really well. And I think the biology question of why can people go 8 to 10 years without needing therapy for a cancer is a fascinating one.
That's a great, 45% 5-year progression by Gelf on a prospective trial. So very interesting data. I've sort of filed that for patients as well. Michael, last word, summary, anything else from our discussion?
I think that the era of doing sort of old school immunotherapy trials is probably past. And you can see that, as John pointed out, there are a host of targeted agents that can be combined with antibodies, can be used. I have no objection to chemoimmunotherapy as frontline therapy. I think it's extremely valuable, but I think there are many more ways, now that we understand immunology of lymphomas so much better, that we can take advantage of our patients' immune systems, allow their immune systems to function and produce better results. So I don't anticipate there's going to be a one of those chemotherapy X versus chemotherapy Y trials again in follicular lymphoma, and there are many other opportunities to explore, and would encourage I think clinicians and their patients to participate in those studies.
I think we'll bring our discussion to a close. John and Michael, thank you very much. And Michael, thank you again for your comprehensive review. I hope people enjoy the rest of the meeting.
It was a pleasure, Peter. Thank you for having me.